Good morning, everyone. My name is Alberta Noonan. I'm from the New England QIN-QIO, and I will be your moderator today for today's webinar, which is Decoding the QPP Year 2 Quality Measure Deciles and Benchmarks to Maximize Performance. Sorry about that. Before we get started, I wanted to review a few housekeeping items. This call will be recorded for training purposes. I'll provide you with details on accessing the recording at the end of the webinar. The phone lines will be on mute for the duration of the presentation, and we will take questions at the end of the presentation. At that time, I will provide you with instructions on how you can ask a question over the phone, and you can also pose a question in the chat box throughout the presentation. Please make sure to send your question to all participants. At this time, I'll pass the webinar over to Leila Zelinsky.
Thank you, Alberta. Good morning, everyone. My name is Leila Zelinsky. I am a Senior Program Administrator and the New England Regional Lead for the Quality Payment Program work. As Alberta mentioned, today's webinar is Decoding the QPP Year 2 Quality Measure Benchmarks and Deciles to Maximize Performance. Just a quick disclaimer that we put on front of all of our webinars. This content comes right from CMS materials, but it is content that we put together, so just keep that in mind. Quick overview of today's webinar. I'll be just briefly touching upon the 2017 data submission, which just ended about a month ago, and then we'll get into quality performance categories, the scoring, benchmarks. And I did, since there's 4 categories now in the quality payment program MIPs portion, want to touch on advancing care information, which there's an update to, improvement activities, cost, and then we'll be providing you with some resources and time for questions at the end. Just briefly, I'm sure all of you are very familiar with these acronyms now in year 2 of the program, but just a couple that you might hear me say would be CMS, so the Centers for Medicare and Medicaid Services, NAPRA, the Medicare Access and CHIP Reauthorization Act, QPP, Quality Payment Program, MIPs, Merit-Based Incentive Payment System, APMs, or Alternative Payment Models, and then we'll talk about some of the rest as we go along. So, 2017 data submission ended on April 3rd of this year. I hope that all of you attending and all of you that work with clinicians and groups were able to successfully submit data to CMS, whether you're under the MIPS portion of the program or the APM portion of the program. If you did submit data, you would be able to see a preliminary feedback score. Now, this isn't a final score, but CMS is doing some preliminary calculations. So if you log into the CMS portal, you can get that preliminary feedback now. Just as a reminder, CMS is hoping to provide final feedback reports at the end of the summer or sort of middle of the summer in about July. Now, I'm not sure exactly whether that will be the final date or if it'll get moved, but look for those reports in July. Also, keep in mind, you will need your EIDM account to be active. We have heard that those passwords expire sometime between 3 months, 90 days, and 6 months. So make sure that you're going into the portal, making sure that your password's still active because you will need that to get your final report. Just quickly before we move on, I see a question. Do you have any insight on benchmarks changing throughout the performance year? So that's actually part of the webinar we'll talk about, so I will get into that as we go on. Also, just want to let you all know that the 2018 MIPS participation lookup tool has been updated. As you can see, I looked up a clinician here, and you can see 2 tabs. There's the Program Year 2017 and Program Year 2018, so you can find out whether your clinicians or yourself are currently expected to participate in the program or excluded based on wherever they might fall. This is also helpful, as you can remember from last year, CMS provided the special status designations, so hospital-based, non-patient-facing, small practice clinicians. You'll be able to find that out now, which might help you plan for 2018. So I'm going to kind of go back to the basics. I want to make sure that everyone is on the same page as we start talking about participation and the benchmarks and how you're scored and the different categories. So just as a reminder, there's two different ways of participating. I'm really focusing mostly today on the MIPs path. We will talk just very briefly about APMs, but if you do have APM questions, this is mostly focused on MIPs. So for MIPs, you can participate as an individual, so that's one single clinician reporting data on your own, or you might have a practice administrator submit your data for you, but you're not part of a group. Or you can choose to report as a group, and the group would be at least 2 clinicians, MPIs, so those are your national provider IDs, coming together and then providing your TIN, your tax ID number, with the right to then report on your behalf. If you report as an individual, you have a couple different data submission methods. So for quality, you can select to report claims-based reporting, and that is only an option for individuals. You can choose to use the CMS portal, EHR Direct, a qualified registry, or a qualified clinical data registry, or QCDR. For groups, you pretty much have the same options, although you cannot choose to report claims as a group. That's only individual. So you can submit data using the CMS portal, EHR Direct, qualified registry, qualified clinical data registry, and if you're in a group of greater than 25 eligible clinicians, you can choose to use the CMS web interface. That's a tool that many of the APMs are using. Just keep in mind that there is a registration period, which is currently open. If you think that you want to use the CMS web interface for reporting anytime between April 1st and June 30th, you can go in and let CMS know that you're planning to use the web interface for your quality data. It's pretty much what you report that through, and then you have that option once it comes time to submit your data next spring, or January to March of next year. Keep in mind, if you're thinking about the web interface, this is a set of 15 clinical quality measures. There isn't an open option like the other choices where you can pick those 6 measures that most appropriately apply to your patients or your practice or whatever your workflow is. For the CMS web interface, you have to report on that designated set of 15 measures, and they're very primary care focused. So now we're going to dive into quality. So for quality, a couple things to keep in mind for program year 2. The first is that currently, under the final rule, you are expected to report your quality data for a full calendar year. So that's looking at January through December of 2018. As many of you probably remember from the 2017 program, this is a pretty big change. One of the elements of the 2017 program was that you could select a single quality measure and literally report on one patient for one instance. Unfortunately, that isn't really an option any longer. The next element to consider is data completeness. And so data completeness is making sure that you are supporting your attestation of data with enough patient data to say that you've met the requirement of that measure. So if you had, let's say, 200 patients in your panel and they were all diabetic, but you only reported on 20 of those patients, you wouldn't be meeting the data completeness requirement because you only reported on about a fifth of those applicable patients for that given measure. For larger practices, so those are practices with 16 or more eligible clinicians, you must meet 60% data completeness in order to earn 3 to 10 points per quality measure. If you fail to meet that 60% data completeness requirement, you'll be capped at 1 point per quality measure. As you can imagine, being capped at 1 point would tremendously affect your overall quality performance score and really hinder your ability to get to that high 70-plus MIPS score to earn that exceptional performer bonus. If you're a small practice, so that's anyone in a practice of 15 or fewer eligible clinicians, you also are expected to meet that 60% data completeness requirement in order to earn 3 to 10 quality points per measure. But because you're in a small practice, CMS has given additional flexibility, and if you're unable to meet the data completeness requirement of 60%, you would be capped at 3 points. So you wouldn't be able to earn any more than 3 points per measure, but as you can imagine, 3 points is much more than 1 per measure, so you'd still get a few more points. Just briefly want to talk about the different types of measures. So under the quality performance category, you are expected to report on at least one outcome measure. So as a reminder, outcome measures typically evaluate patient health as a result of the care received. So as you can imagine, this is an outcome for something that you've already done. So an example here is, what's the amputation rate for patients with diabetes? A lot of the measures that you'll see in the MIPs program are process measures. So those are measures that determine if a service has been provided to patients in the typical course of clinical care. So an example would be, how is that provider ensuring that all patients receive their flu shot or pneumococcal vaccine or mammogram or colorectal cancer screening, anything to that effect. I'm going to jump down to the bottom. Another aspect that if you can't find an outcome measure that meets your practice type or patient panel, you could choose high priority measures, and there's quite a few of these to choose from. High priority measures are measures that evaluate outcomes, appropriate use, patient experience, patient safety, efficiency, and coordination of care. So these really cross all settings of care. That's why they're considered to be high priority, because CMS has deemed them to be high priority areas of focus. So an example here would be percentage of patients with acute bronchitis who were not dispensed an antibiotic prescription. So again, that's appropriate use of antibiotics for patients with bronchitis. Two other categories you might see a little less often than the others are patient experience. So again, that's just as the name would denote. That's providing feedback on patient experiences based on the care that they were provided. So what was the patient's experience with the provider's communication about their care plan? Did they meet their expectations? Whatever the case might be. And the category that there are only a handful of measures on are structure. These assess the characteristics of the care setting, so it's facilities, personnel, policies related to care delivery. You won't see many of these, but an example would be, are there adequate staff in the emergency department when there's an event going on in town? So do you have first responders? Do you have staff? Should there be some sort of major event that could bring in all of those patients and care for them appropriately? So as I mentioned before, the different types of data submission. So if you choose to report any method other than web interface, there are two different point structures that you're capped at. So if you're in a larger group, so again, that's 16 or more eligible clinicians, and you report on 6 quality measures, and you then get put into a group that potentially would be reporting on that one additional readmission measure, so you have to have adequate case volume, so it's 200 cases in order to be put into that group, you would be capped at 70 total points for the performance category. So for quality, the most points you could earn would be 70. Now, we'll talk a little more about that, but it gets a little confusing because 70 isn't in fact the total MIPS points that you would earn for quality. You're capped at 50 MIPS points for the category. If you don't report on that one readmission measure, the total points you can earn would be 60. If you choose to use the CMS web interface, then you would report on up to 120 points of data. That's for groups that are required to submit the measures plus that one readmission measure. Those are groups that fall into the MIPS side of web interface reporting. If you are in the web interface reporting side and a group that is not required to submit the readmission measure, often those APMs, you are capped at 110 points. So a couple different things to consider about the number of points that you might be eligible to earn. So for quality measure scoring, again, quality measures make up 50% of the total MIPS score. The way the category is calculated is the total number of points that are earned plus any bonus points that you earn over those total possible points. So that's why it's really important to know, are you in the 70 possible points, the 60 possible points, the 120 possible points? And that calculated out equals your total quality category score. So I want to talk a little about the scoring points breakdown because there's so many different components. I know it gets really confusing. These are how you earn points within each measure that you're reporting on. So the first is the decile performance score. So as I mentioned before, assuming you meet data completeness, you can earn 3 to 10 points per measure. This is all dependent on your overall performance within that measure. So if you're able to get to 95% performance, then you're likely going to get a higher number of points per measure than if you were only able to get to, let's say, 15 performance score. So each performance point on a quality measure is based on that percentage achievement, and it's associated with the 2018 benchmark, which actually, I apologize, and I didn't put in. I'm going to enter that right into chat now. This is a link to the benchmarks for 2018. If you have any questions, definitely make sure you check that out. They didn't change much from 2017, but this is the tool that will be used for 2018. The next is a bonus that you can earn by reporting on additional high-priority outcome or patient experience measures. If you choose to report on more than that required one outcome or high-priority measure, you can earn at least 2 bonus points per outcome or patient experience measure you report on, or 1 point for additional high-priority measures. Again, you'd have to be above that required initial outcome or high-priority measure. If you report end-to-end reporting, so this is utilizing your certified EHR, so electronic health record, to report that data. So you just basically pull the data right from the EHR and submit it to CMS. That can either be done directly through your EHR on your behalf, or you can submit that QRDA3 file through the portal. You would earn 1 bonus point per measure. So lots of opportunities to get additional points if perhaps your overall decile performance score isn't quite where you want it to be. So lots of things to consider. So something about the benchmark. So again, benchmarks are created off of national benchmarks. CMS pulls all of the submission data over about a 2-year period, looks at where the different measures are scoring, and tries to figure out what those appropriate benchmarks are. As you'll see in a couple of minutes, it varies depending on the submission method you check or you end up utilizing. So be sure to check to make sure that you're utilizing the method that gets you the most points, that makes the most sense for your practice, your group, and then go from there. As I mentioned, there has to be sufficient case volume in order for there to be a benchmark. CMSs usually use the 20 cases in order to say that this benchmark is reliable and accurate. As I mentioned with the readmission measure, you have to have at least 200 cases. Again, you need to have data completeness criteria met in order to get the full decile score available. And then this came up a couple times in 2017. What if I happen to select a measure that there isn't a benchmark currently available for? So CMS will do its best to create a benchmark for you, but again, it's dependent on whether more than 20 cases and sufficient data was submit for them to create a reliable benchmark. If a benchmark cannot be created based on the amount of data that was submitted to that measure, you would be capped at 3 points. So the question that came up a lot in 2017 was, this measure really seems to apply most to my practice or my patient panel. I would like to make sure that you get the most points. But if you select a measure that doesn't have a benchmark and CMS isn't able to calculate it, you are sort of shortchanging yourself because you're capped at that 3 points. So it would really be beneficial if you're able to select a measure that does have a validated benchmark, because you'll be able to get that additional 7 points potentially based on your performance. So just keep that in mind. It's definitely worth looking into, and CMS doesn't let us know what measures they'll be creating benchmarks for until later on in the year once the data's all been submitted. So this is what that benchmark document looks like. I did compress it a little so that it would all fit onto one page. A couple things to keep in mind here as you look at the data. So on the far left side, you'll see measure name. So that measures for the diabetes hemoglobin A1C for control measure. It's measure number 1. In the third column over from the left, you'll see that there's a submission method column. This is key to determining what submission method this specific benchmark is for. So as you can see, it goes claims, EHR, registry, QCDR. So if you choose to report claims, you'll want to make sure you're looking at all submission method claims. For 2018, CMS is not allowing you to mix and match submission methods, so you would need to stick with one submission method per performance category. So you want to report on all claims for quality, and then all EHR for advancing care information, and so on. So just going off this example, So with claims EHR registry reporting, you can see that the measure type is outcome. Again, that's really important to know what kind of measure this is. The next, you'll see that there's a column bench. It does say benchmark. I abbreviated it because I need some space. And you can see a yes. This is where you'll see if the measure doesn't have a benchmark, it would say no. And that's where you'll know, okay, I might be capped at that 3 points. The average is the average score earned per measure. Then you'll see all the different deciles. So the lowest number of points you would earn would be 3, even if your performance is below decile 3's performance threshold there. Goes up to decile 10. Next, we have topped out. Topped out measures are measures that CMS has been monitoring for some years, and oftentimes performance has gotten so high that really that measure is considered to be topped out. So in order to get 10, well, let's say 9 to 10 decile points, you would pretty much need to have perfect performance, which we know is really unlikely because when you're working with patients, oftentimes it's nearly impossible to get to that 100% performance. If you see topped out yes and 7-point cap, that would mean that that 7-point cap has been put into place for this measure. There's only 6 for 2018, and these are measures that have been topped out and now are in the process of being phased out by CMS, again, because their performance has been so high for so many years that really it's no longer efficient and effective to be tracking their progress. If it's a 7-point cap, as you can imagine, you're only able to earn up to 7 points, not the full 10 points. I don't think I list those measures, but if you have questions about those measures, we can let you know what they are. It's a very select set of very specific specialty measures that more than likely you wouldn't be choosing unless you're one of those specialists. So in this example, as you'll see, so for claims, the average of 22 would put you in roughly the mid-decile 4, so you'd earn about 4.5 points. If you're reporting through your electronic health record, you would be somewhere in the 5.5 point range for your 49.4 points. And then for your registry or QCDR for your 34.8, again, you fall back into that 4.5 or so point range. So hopefully this shows you that there's a pretty big variation. I think the next example has even more variation, but depending on the submission method you select, you really could earn anywhere between 3 and 10 points based on your performance. So here's the breast cancer screening measure. Again, the same claims EHR registry. They always follow that same sequencing. So you'll know which measure and which submission type you're selecting. Again, the average puts you in the 5th decile for all of the different categories, which is very unusual. For the documentation of current medications in the medical record, again, you'll see the different reporting types. And here's an example where this is a topped-out measure. So you'll see yes and topped out. And as you can see with the performance, so let's look at claims quickly in that top row. In order to get just into decile 3, you have to have 97.2% performance. And to get decile 5, you're 99.8 to 99.99, so nearly perfect. And unless you have a perfect 100, you're not earning 10 points. And there's a pretty big spread between even nearly perfect and perfect. So really tough to get that. That's why this measure is being topped out. It is not yet part of the phase out, so it's not in that 7-point cap group. And again, for this one, you'll see all of the categories average puts you right in that 3rd decile. So here's one that really has a lot of spread based on the submission method that you choose. This is the screening for clinical depression and follow-up plan. Again, claims, EHR, and registry. For claims, a 65.3% performance will put you in decile 5, about 5.5. For EHR, you're in the 7.5 range for your 28.4. And then in the registry QCDR, the 63.4 puts you again in the 5th. And you can also see here the pretty wide range of reporting averages. So claims and registry really expect you to have significantly higher performance, almost triple what that is of the EHR in order to get even fewer points. So this is why it's really important to start considering, okay, how am I reporting and what makes the most sense? Now, please don't think that just because this one example is higher for EHR that all measures are higher for EHR. It does vary a lot between the measures, but keep that in mind as you start working through your practice and your chosen measures. I'm now going to go through how you would calculate. Oh, actually, we'll talk about that in a minute. I do want to just briefly mention the eligibility measure applicability. So this is a process similar to something that was in place for the physician quality reporting system. If you happen to submit fewer than 6 quality measures or you don't select that outcome or high priority measure, CMS will go through a process where they determine if you could have reported on additional measures. If CMS finds that you could have potentially reported on additional measures, usually these are specialty measure sets, then you would be capped at a higher rate of performance. If the process finds that there aren't additional measures that you need to report on, your quality score will remain the same. So basically they'll lower it to say, okay, no additional measures were applicable to you, so then your total applicable measure score is then lower, so you can actually perform higher. Just as a reminder, this isn't applicable to those of you that are reporting through EHR Direct, the Qualified Clinical Data Registries, or the web interface. So that's basically just those of you using claims or the qualified registries. So again, just make sure that you know if you have additional measures that are applicable to you. So a quick example. This is going to be for a larger practice that chooses to report using, let's say, EHR as their method because they're getting the bonus points for the EHR, and they're not eligible for the readmission, all-cause readmission measure. So the way it works is you would look at the total performance percentage, and then going across, I don't have the decile benchmarks pulled up, but this percentage would earn about 8.2 points. They would earn the EHR end-to-end bonus. It is their required outcome measure, so they're not getting any additional bonus measure points there. This group also chose to report on closing the referral loop. They got 41.1%. They did get that EHR bonus as well. This is a high priority measure, so since they already met the one required outcome, they're getting 1 bonus point for that being an additional high priority. And then they earned 5.6 points based on their 41.1 performance. Depression utilization of the PHQ-9 tool, they had 7.4% performance. Again, they got the end-to-end reporting bonus. It is not a high priority or an outcome measure, so they did not get bonus points there. And their performance earned 7.8 points. Controlling high blood pressure was at 72.6. Again, they got the end-to-end reporting bonus. This is an intermediate outcome measure, which does count as an additional outcome measure, so they got 2 points for that, which put them at a score of 8.5 points for overall decile scoring. Use of high-risk medications in the elderly, 13.8% performance. Again, the 1 point for end-to-end reporting. This is another high priority measure, so they got an additional 1 bonus point. That put them at 3 points for overall score. And they also reported on the pneumococcal vaccination for older adults, which was at 55.3. Again, the 1 end-to-end reporting bonus point. It is not an outcome or high priority, so they didn't get any bonus points there. And they earned 6.8 points total. So, and I apologize for this being a little confusing. I'm going to jump over to the bonus points first at the bottom. So if you get the 6 EHR end-to-end bonus points plus the 4 bonus points they got for the 2 additional high priority and 1 additional intermediate outcome, that gives them 10 bonus points. Their overall performance score is that score column added up, which gives them 39.2 performance points. So 10 bonus points plus 32.9 performance points gives them a total of 49.2 points. Because they are in the non-reporting of the all-cause readmission measure, their total points possible for this category are 60. So they have the 49.2 points over 60 points, which gives them 0.82. And again, because quality gets you 50% of the MIPs score, they come out with 41 MIPs points for the category. So a couple kind of crazy calculations in there you have to do, but overall, if you pull your total score and your bonus points and put that over your possible points, you would get your overall total points. And there's their total net score. So I'm going to head into advancing care information now, which as of last week, April 24th, has been renamed. This category will now be called Promoting Interoperability. This is a program that CMS is trying to move away from meaningful use. Obviously, advancing care information had already moved away from that name. But really the goal is to do just that, promote interoperability. So the goal is to make sure that all of our EHR systems are working with one another, passing data easily back and forth, that's usable data. I don't have a lot of information on exactly how promoting interoperability will be phased into the program, but just know a big component of this is to reduce the required measures, to keep the reporting period at 90 days, and to really make the measures more applicable to what's important to practitioners. So one of the caveats of that would be adding in a piece to the e-prescribing measure that looks at the prescription drug monitoring program and utilization of that program. So making sure that if patients are seeking medications, those opioids that we know is a major crisis across the country, that prescription drug monitoring program, or whichever the state is, has been consulted, that information is being seamlessly passed between clinicians to make sure that you know if that patient maybe has a drug-seeking problem and needs to get additional levels of help, or if you can get them onto a pain contract. So really looking at kind of pulling all that together. Still heavy focus on utilization of the portal, utilization of those summary of care documents being sent, but kind of a movement away from just the standard, okay, meaningful use, how do we utilize our EHR and demonstrate that we've done what we've been expected to do. So more to come on that once we have some information. CMS is currently in the comment period, so if you have interest, please let us know. We're happy to get you the information so that you can comment on promoting interoperability and make sure that program makes the most sense for you. So I'm going to talk about advancing care information as it currently stands because, again, nothing has changed quite yet. But just know there are changes coming down the road. So advancing care information currently accounts for 25% of your MIPS score. There are a couple components to that score. So there's a base requirement, which we'll talk about in just a moment, and then there's also a performance and a bonus score. So you get your base requirement. If you don't meet the base requirement, you can't earn performance or bonus points. You're capped at a total of 100 points for the category, and that gives you your total category score. So we'll get into that a little more. So for the base measure requirements, there are two different categories that you would fall into, depending on which EHR certification year you have. If you have a 2015 certified EHR, you'd probably select the advancing care information measure. Those are kind of in the line with the meaningful use stage 3 measures. So that's looking at security risk analysis, e-prescribing, providing patients access to a portal, sending a summary of care electronically, and then requesting and accepting that summary of care. The e-prescribing and the summary of care measures have exclusions. If you have fewer than 100 permissible either e-prescriptions or transitions or referrals during your reporting period, you would be excluded. You can take that exclusion right in the CMS portal. If for some reason you report on all of the measures and you are unable to meet at least one in your numerator, you would miss the entire base requirement and get a 0 for the advancing care information score. So really important to know where you fall in terms of your measures. If you are on a 2014 certified EHR or a combination 2014-2015 or even 2015 certified, you can select the 2018 advancing care information transition measures. These fall in line with the meaningful use stage 2 modified measures. So very similar to the other set, it's the security risk analysis, e-prescribing, providing patients access to a portal, and then health information exchange. That's the same of the send the summary of care document. Same requirements if you have fewer than 100 e-prescriptions or fewer than 100 referrals or transitions, you can take an exclusion from the e-prescribing and health information exchange measures. If you don't meet at least one in the numerator, you are also not able to get performance measures and you would lose the base score. For the Advancing Care Information 2018 measures, there are 7 performance measures. You can earn, so these are actually the transition measures, I apologize, it doesn't say that there. You can earn up to 20 points for the Provide Patient Access and Health Information Exchange. If you'll recall, those should look very familiar because they are pulled over from your base requirements. You actually get double points for those. And then there's a lot to do with the portal. So view, download, transmit, secure messaging. There's also providing patient-specific education, medication reconciliation, and then just a yes-no for the registry, immunization registry reporting if you're either doing that or not. In many states, there's different tiering to getting into that system. The state might not be able to accept registry transmissions yet, so you can see where you fall, but you can still take that yes, even if you're sort of in the process of getting online with the system. If you're just following the regular Advancing Care Information measure set, these measures should again look very familiar. So it's providing patient access. You're capped at 10% for this group of measures. The send and request and accept the summary of care and send the summary of care, view, download, transmit, patient-specific education, secure messaging, medication reconciliation, clinical information reconciliation. This is very similar to the request and accept the summary of care. So that's pulling in either patient-provided data or other data that you're pulling right into your EHR and then utilizing it in some way. So it could be allergy data, could be medication data, could be test data. It's really whatever works for your organization and what you can get in. And then also that same immunization registry reporting. So those are the performance measures. The bonus measures are for 5% total, even if you report to more than one. You can get a 5% bonus for submitting data to public health or clinical data registries. You can get a 10% bonus if you utilize your electronic health record to report on an improvement activity. There's 18 that pull in the EHR. You are, again, capped at 10% bonus for that. And then if you happen to be on a 2015 certified EHR system, you actually get an additional 10% bonus. So it's kind of nice. If you've worked to get onto the 2015 certified system, you'll get a little bit of a bonus. Couple things to consider. So there is some category reweighting. As I mentioned in the beginning of the presentation, there is that special status consideration. So if you are a clinician that is considered to be hospital-based, non-patient-facing, ambulatory surgical center-based, nurse practitioner, physician assistant, clinical nurse specialist, or certified registered nurse anesthetist, you are not required to submit advancing care information data. And just by the very nature of your status, your advancing care information category would be reweighted to 0, and quality would become 75% of your score. So that 25% automatically just goes right back to quality. If you are part of a group, there's a couple things to keep in mind. Groups have to meet different requirements. So in order to report as a group that would get their score reweighted, if you are in a hospital-based group, 100% of that group would have to be considered hospital-based. If 100% of your group was considered hospital-based, then you would be able to report as a hospital-based group that would have their category score reweighted to 0, and quality would become 75% for 2018. If you are in a non-patient-facing group, then 75% of your group would also have to be considered non-patient-facing in order for them to receive the same reweighting. So just keep that in mind. The lookup tool is great, and it actually will show you if, as an individual, you're considered whatever special status, or if your group is considered whatever special status. For the hardship reweighting, CMS is allowing for hardship exemptions this year. That application has not yet been made available, and it will be required to be submitted to CMS by no later than December 31st of this year. Some of the options that you have would be that you're in a small practice, that your EHR potentially was decertified sometime during the performance year. You have insufficient internet connectivity if you're in that rural setting or something happened, maybe a natural disaster. That also falls in line with have extreme and uncontrollable circumstances. So many of you that were in, if you're listening from the South that were hit by the hurricanes last fall, due to the extensive damage, you might fall into that extreme and uncontrollable circumstances exclusion group. And then if you're considered to have no control over your EHR. So this is really where those hospital-based clinicians fall in, because they work in an organization that pretty much provides them with an EHR, and they don't have a whole lot of control over that actual EHR. So examples for advancing care information scoring. So this is the excuse me, the 2018 transition measure set. So this practice was able to do their security risk analysis successfully, so they got that. It is a required base measure, but it is not part of the bonus, so there was no bonus score awarded. E-prescribing, they earned 84.7 points. It is required and not part of the bonus, so again, no bonus points were awarded. For provide patient access, they earned 72.8 points. It's required and is part of the bonus. And if you recall, for the transition measure set, you earned double points. So they actually earned 16 bonus points there, or bonus percentage points. Health information exchange, they were at 3.1% performance, earning them 8 bonus points. Medication reconciliation, 52.4. Again, this is not a required measure, but it is a bonus, and that got them 6 additional percentage point bonus. Patient-specific education, 55.3. Again, not required, but part of the bonus, so they got another 6 percentage points. View, download, transmit, they got 31.6. Again, not required, but part of the bonus, so they got 4 percentage bonus points there. They did report to a specialized registry, so they were not required to do that as part of the requirement, but was a bonus getting them 5%. And then the EHR-related improvement activity, again, got them 10. So similar to how we did it in quality. Total performance bonus points, if you go down the score column, that was 55 bonus percentage points. Because they earned their base score, they earned 50% of the total 25, so that gets them 12.5% points. So adding 55, 12.5, they get 67.5 points. Again, you're capped at 100 for this category, even though you could earn up to about 155 points. That gets them 0.675 of the 25, so they're earning 16.87 MIPs points for the category. All right, next category, so we make sure we have plenty of time for questions, is improvement activities. So I'll go through this pretty quickly because scoring is pretty straightforward. Improvement activities account for 15% of your MIP score. If total points earned over total possible points gives you your category score. As a reminder, practices of fewer than 15 eligible clinicians report on 1 to 2 activities to receive full credit. That's either 1 high-weighted activity or 2 medium-weighted activities. For larger practices of greater than 16 eligible clinicians, you would report on 2 to 4 activities to receive full credit. So that's either 2 high-weighted activities or 4 medium-weight, or any combination of those 2. If you are patient-centered medical home or PCMH recognized, you would earn full credit for this category, and you must report for at least 90 days. There are all of these different categories available to choose from. So, quick example. This practice reported on care transition documentation of practice improvements. That's a medium weight. So that 1 activity would earn them 3.75 points. They're also annually registered in the prescription drug monitoring program. That is also a medium weighted activity. They earn 3.75 points for that as well. Implementation of an antibiotic stewardship program, again, a medium weighted activity, earning them 3.75 points. And then they engaged with the QIN-QIO to implement a self-management training program, also a medium weight activity, earning them 3.75 points. So because they did 4 medium weight activities, that got them their total 40 points needed and their total 15 points for the category. Cost. Now, we'll spend a little time on cost. because cost is the new category for 2018. As a reminder, cost accounts for 10% or 10 points of your total MIPS score against total points earned over total possible points, and that gets you your cost category score. So there are two cost measures. The first is total per capita cost. This is calculated from all of the Medicare Part A and Part B costs during the MIPS performance period, and this is for a full calendar year of data for patients that are attributed to a provider. So the way attribution works is that patients are only attributed to one provider using a level of primary care services that were received by that clinician, or by that patient by that clinician. So it's very similar to the way ACO participants get their attribution of different patients. So it looks at how many dollars were spent in caring for that patient over that period of time and which clinician was responsible for providing the most number of services to that patient. Similar to that, there's also the Medicare spending per beneficiary. This is calculated based on what Medicare pays for services performed by an individual clinician during that Medicare beneficiary's total episode of care. And a total episode of care is considered to be 3 days prior to whatever the encounter was, during that episode, so during their hospitalization, and then 30 days post-hospital stay. So it's really looking at a period of time that could be anywhere from, let's say they were hospitalized for 2 days, 35 days, or up to, 60 or more days if they were hospitalized for quite some time. So utilizing that, the way the cost category score is calculated is it's the average of those two measures put together. Each measure can earn 10 points. So let's say for the total per capita cost, this group earned 5.6 points of the total possible 10. For Medicare spending per beneficiary, they earned 7.2 points out of the total possible 10. So 7.2 plus 5.6 gets you to 12.8. 12.8 over the total 20 gives you 0.64% times the 10 would give them a total of 6.4 MIPS points for this category. So, just quickly, we'll go over total scores. So from the quality category, they had a total performance of 49.1%, which gave them 41 MIPS points. Advancing care information earned 65.5%, which got them 16.37 points. Improvement activities, they got the full 40, so that gave them the full 15 performance points. Cost was 12.8 points, which got them 6.4 points, points. So all together, that got them to 78.77 MIPS points. And as you might recall, there is an exceptional performer bonus for those of you that are able to get over 70 MIPS points. So this group would be eligible for some of that exceptional performer bonus. I see lots of questions coming in, so I want to make sure I get to those. Just quickly, there are resources on our New England QIN-QIO macro page. It's neqpp.org. You can ask us a question there. There's also the CMS Quality Payment Program website. It is currently in the process of being updated to 2018, so there are some things that are still 2017 and some things that are 2018. Just know that that's a work in progress right now. All right, so let's get to questions. I'm also going to jump ahead. If you have specific questions that you don't want to ask now, feel free to email me, and I will try to get back to you. I'm going to scroll up. Let's see. Aaron asked, will the changes to ACI measures to interoperability start in 2019? Yes. So the interoperability program, the promoting interoperability, would not take effect in 2018 because that will not be finalized until sometimes probably mid-summer, which just wouldn't allow enough time to get that into the 2018 program year. So you'll see those changes come in 2019. Thank you. Question from Lucy. How does a specialty practice analyze the impact of HIE using 2015 CERT for incoming referrals? We need to purchase an additional program from our vendor for this called Direct. They keep telling us we may be missing incoming referrals. I don't know if we can use mixture of 2014, 2015 cert. So without knowing all of the nuances of your EHR, which will probably be helpful in this example, you can definitely use a mixture of 2014, 2015 certified technology. You want to make sure that both systems are certified. That's the crucial element here. It has to be certified in order to count. Depending on what your current process is, yeah, I mean, I'm not sure based on what your EHR is, but if they're telling you, if your vendor's saying that you're missing incoming referrals and that there's a module, that's entirely possible. If you want to give me an email, we can chat about it offline. I don't know your specifics, so I can't specifically comment on those, but we could definitely chat about it and see. I will say that some vendors have been known to upcharge for specific modules that are required to do some of the features needed to successfully report. So just keep that in mind, but I'm happy to talk to you offline about it. I think this is probably a very specific example. Immunization registry is not a bonus. It is part of the performance score. So it doesn't fall into that clinical data public health group. It's kind of a separate component of the performance score. Question, I do think there are actually 28 measures this year for the improvement activity bonus for advancing care information. That would be awesome if they increased it. I hadn't seen that, but there might be more measures, so maybe more than 18. How do you calculate the double score for ACI for those that get 20%? I'm not sure I understand the score. So the two measures in the Advancing Care Information 2017 or 2018 transition measure set that earned 20% are the providing patients access to the portal and the health information exchange. The way that you calculate the bonus, I'll just jump back to that quickly. Sorry, lagging. So this doesn't actually show you the bonus, but the way it works is just consider here that you would get double the points. So if you earned, let's say for that measure, 25 performance points, you would get between this 21 and 30, so you would get 6. So you just simply double the score for those two measures between, 2 and 20 is what you can earn. Back to the end. All right. For specialty reporting for 2018, does it depend on 2014 versus 2015 search to determine which 3 options must be met? Lucy, I'm not sure what you mean by that. Could you either, you're more than welcome to hop on the line as well. If you'd like to ask your question over the phone line, it's #6 to ask it, or you can enter into chat. Lucy, could you just provide a little more information on what you mean by the 3 options? I'm not sure I understand exactly what you're referring to there.
Hello.
Hi.
Hi. Follow-up to this question is we registered with a specialty-specific registry, and depending on which version of CERT we were using, last year we used the 2014 version because they were not certified yet for 2015, which they now are, and there were 3 options to get that bonus. I think it was just one was just showing proof that you're registered. And then I think the second one, depending on the cert year, was active engagement. And I'm not 100% sure because we're going back and forth between myself, the EMR vendor, and this registry about what active engagement means. Does it mean that you actually have to submit the data to them or not? So my question was, does anyone know what the 3 options were as far as the registry, and what are they for us to make a decision as to what we have to show as engagement?
So I can't remember, just give me 1 second. I can't remember for 2015 if they offered the 3 options or not, but I actually just was talking to someone about this for 2014 earlier today. So I can speak to it for 2014 at the current time, and then I'll look for 2015 for you. So the 3 options are, option 1 is completed registration to submit data. So the MIPs eligible clinician registered to submit data to the public health agency, whichever it is, in your state or whomever, to which the information is being submitted. Registration was completed within 60 days after the start of the MIPS performance period, and the MIPS eligible clinician is awaiting an invitation from that public health agency to begin testing and validation. So it's really in that sort of, not even testing yet phase. This option allows MIPS eligible clinicians to meet the measure when the public health agency has limited resources to initiate the testing and validation process. MIPS eligible clinicians that have registered in previous years do not need to submit an additional registration to meet this requirement for each performance period. So that's option one. Option two is testing and validation. So the MIPS eligible clinician is in the process of testing and validation of the electronic submission of data. MIPS eligible clinicians must respond to requests from the public health agency within 30 days. Failure to respond twice within a MIPS performance period could result in the MIPS eligible clinician not meeting the measure. And then three is production. So the MIPS eligible clinician has completed testing and validation of the electronic submission and is electronically submitting production data. So that means you're actively sending data back and forth. Usually it's in a one-way. Anything that's applicable to that registry, you'd be sending that off to them as that patient data comes through. Does that help answer your question?
It does, but I think there was a change in the in 2015 that also changed these three options, because we were in touch with the registry and they provided us for our book of evidence just a letter that says that we have completed the registration process. The question we have now is, where is it at? How have these three options changed, right, in terms of what CMS is requiring to get the bonus point? If all we've done is completed the registration and we haven't actually tested or sent anything, then what?
And so you're using 2015 for sure this year?
Well, we could use either one because they're both certified. It's going to depend on which one produces a better result for us. Obviously, you get bonus points if you do 2015, so that's why they're probably wanting us to use 2015.
Right. So for 2014, the options have not changed. Those same options that I just listed off are the same. And for 2015, well, this is for immunization. I should add that piece.
We're doing specialized registry.
Okay. Security.
And I don't want to take time from other people that have probably a lot of questions, so if you want to, send me an email. Yeah, they have, I registered, and I think I've been registering for a lot of your programs, but I'll send you an email, and I'll ask, I'll give you mine and ask the first question that I had posed also.
Perfect. Excellent. Thank you.
Thank you. I want to be, obviously respectful of other people's time.
Absolutely. That sounds good. Thank you.
You're welcome.
Okay, let's see. Could you confirm page 28, ACI scoring isn't the 12.5% part of the actual MIPS points? Yes. So if you earn the bonus, if you earn the base, you would get 12.5 MIPS points, but that gets all carried over. So it's 50 points of your, oh, I see what you're saying. Did I miscalculate that? I might have, sorry, I might have miscalculated their advancing care information score. Yep, so it should be 37.5 points higher than that. So they would actually have gotten 100. They would have capped out at 25. So their score would be a little higher for their overall MIPS. Thank you, Julie, for pointing that out. I apologize. I was thinking final MIPS points and not the base score. Can you give any examples of specific scenarios on how to calculate costs for patients? Brooke, that's a great question. Without data, it's really difficult to calculate that. So not at this time, but if you have specific data, we can try to work through that with you. You're more than welcome to email me. Sorry, my screen's frozen up. Will health, I think that's supposed to be health plans gain access to provider scores? Sheila, I'm not sure. All of this data is potentially publicly reportable, so your score and your overall group's performance may be made public, and in that case, health plans would have access to the scores, depending on how you submit your data. I only started submitting quality measures on 2018 claims in March. Will this affect us? So for 2017, obviously, no, you wouldn't have that. But for 2018, yes, you will have missed a chunk of time, but you might be able to pull that data in retroactively. Are all of those claims from March, have they been submit and processed, I guess would be the question. Kathy, yes, groups do need to register to report CAP data. It's similar to using the web interface. So you can go to the CMS website and there is a location for submitting that registration. And CAP is still optional, so you don't have to do that if you don't want to. Have they calculated the bonus scores for over 70 for 2017? No, not yet, because the submission period just ended in April, beginning of April. So that would be coming in July on your final report. Copies of the slides will be made available. I believe the link was added in chat earlier. Let's see, we're part of an ACO. Should PAs and APRN statistics be included in advancing care information calculation? So, interesting question. We have heard differing information on this from CMS, but I would say yes. If you can pull in your PAs and APRN's information, it would definitely be helpful. There is a requirement if you're part of a Medicare Shared Savings ACO that all participants report on it's ACO 11. It's the meaningful use measure. So it would be helpful if you can pull that in because you'll help take care of that measure's requirement. Oh, thank you. Alberta entered the link to the slides. I can definitely make a correction to the slide 28 and then make it available again. So I would say just hold on downloading it and we can update it. It won't be until later today, though. We're a couple minutes over. Any final questions? If not, feel free to email us. We are happy to help you out and hope that you have luck in preparing for year 2. Great. Thank you all. Take care.